So to our international guests, colleagues and students, welcome on behalf of the International Psychoanalytic University Berlin and the University Management. Of course, I would like to welcome everyone to today's webinar. International online events like this serve to spread psychoanalysis not only within the university context, but also to the greater community, both local and global. Therefore, I would like to thank all of our attendees for their continued interest in the IPU and their mission. Especially, I would like to thank the visiting professors from our Horst Kächele Gast Professorship, Mark Solms from the University of Cape Town, South Africa, Heidi Levitt from the University of Massachusetts, Boston, and Christopher Muran from Adelphi University, New York, for their engagement and involvement with the IPU over the last 2 years. Respective for semesters. Their presence at our university has helped to strengthen our international profile and allowed for the creation of several international cooperations, which we hope we will continue and expand in the coming years, some of which you will hear about today, so I'm told. Many thanks to Andreas Hamburger and also to Carmen Scher, head of our international office, for initiating and establishing this DAAD visiting professor program at the IPU Berlin, and to Andreas Hamburger again for the moderation of today's event. I'm looking forward to hearing what you have in store for us, together with our young colleagues and the guest professors of the visiting program. And now I will give the floor to Andreas Hamburger. Thank you for attention.
Yeah, thank you also very much, Mr. Olbertz. Having been thanked so cordially, I try to do my job as good as I can.
I know.
Yes. And just hello to colleagues and friends. I see a lot of friends also in the participants list. Let me also welcome you to the concluding conference in the Horst Kächele webinar series at IPU, and just say a few words on who is our titular saint. Professor Dr. Horst Kächele was a medical doctor, psychoanalyst, and also a late psychologist. He did a doctoral dissertation with 70 years, who has been with us since the founding of our university, but sadly passed away in 2020. He was one of the most important advocates of a research-based and clinically sensitive psychoanalysis at the same time. His book, his seminal 3-volume textbook, edited together with Helmut Thurme, is a basic text not only for German psychoanalysts. It has been translated also not only to English, but also to, just to show a few examples, Bulgarian and many other languages. I stopped counting at 15 editions from now. So in his spirit of curious interdisciplinarity, which, by the way, also characterized the physician and neuroscientist Sigmund Freud, with his strong affinity for and network in psychology and cultural studies, we dedicated the Horst Kächele webinar to academic dispute, as we will have it today, hopefully. Let me briefly greet our guests. It's impossible to really present them. Professor Mark Solms is a neuroscientist, psychiatrist, and psychoanalyst, founder of the journal and of the Society of Neuropsychoanalysis, editor of the revised standard edition of Freud's psychological works, and himself writing an exciting revision of psychoanalytic metapsychology from its earliest beginnings with Freud's project of 1895. That's really an exciting text. He's one of the central inspirations of contemporary psychoanalytical theoretical discourse. In his guest semesters at IPU, He mainly worked on connecting students and researchers to the field of neuropsychoanalysis. Here are some of his books. Professor Heidi Levitt is a professor of clinical psychology at the University of Massachusetts. She is the editor of Qualitative Psychology and the past president of the Society of Qualitative Inquiry in Psychology. She's a most influential person for reporting standards for qualitative and qualitative meta-analysis and mixed methods in the publication manual of the IPA, as well as a member of the Clinical Practice Guidelines Committee at APA. Her research is concentrated around psychotherapy research and LGBT plus, Q plus research. In her time as Horst Kächele guest professor, she launched a fantastic project that is an international initiative on improving inclusion of qualitative research in psychotherapy guidelines. Professor Chris Muran is one of the most influential transdisciplinary psychotherapy researchers of today. He too is a member of the APA Clinical Practice Guidelines Committee, and he is past president of the SPR. I show only 3 of his 10 published books. He's best known for his expensive, maybe also expensive, extensive and seminal research on the therapeutic alliance, especially processes of rupture and repair, and the development of the rupture resolution rating system, 3RS, that will also be discussed in this webinar. He shared his deep knowledge on the therapeutic alliance to students and colleagues from IPU, and I am personally very grateful for his supervision of my research project on a multi-method description of moments of meeting in psychotherapy. I'm not going to present our young researchers, Sofia, Kontaxi, Jenny Eis, and Marie Siebert, and their projects, since they are going to present themselves in a minute. I will just thank them for their readiness to represent research activity at IPU and expose themselves to a public discussion with big shots. I would have quite a bit of stage fright at their age at such an occasion. So let me very shortly outline the schedule for this afternoon. After this introduction, which is going to end in a minute, the young researchers will present their projects and the professors will comment on them. And then we have a short period of questions and comments from the audience. Please don't put your questions through the chat, but just raise your electronic hands if you want to comment anything on these projects. Then we will have a short 10-minute break. And after that, in part 2, we will start with presenting a short video, a therapy video, a vignette that can then be discussed on the panel. But before that, in breakout rooms for the audience, only 15 minutes. And we would ask you to agree on a keyword that you can agree on in those breakout rooms and write it after the closure of the breakout rooms in the Mentimeter. You will get the link from our administrators. So the Mentimeter will grow and we will see what our audience addresses, what kinds of keywords would be addressed. And so our guests and the presenters can react to those keywords. We thought that might be a good method to give you a voice without taking too much time for, co-referates from the audience. And then the last quarter of an hour, we would dedicate to just a concluding remarks of our most estimated guests, and also the young researchers who have cooperated with them, or on the experience of this guest professorship program. Maybe we can also motivate our university to continue the program in the future after DAAD unfortunately has closed it, but maybe we can do our best to give it another chance. So that's for today. Let the games begin. Thank you.
Hello, everyone. My name is Jenny Eis, and I'm a research associate and doctoral student working in psychoanalytic psychotherapy process research with my supervisor, Professor Dorothea Huber at the IPU Berlin. And this kind of psychotherapy process research is really fascinating to me because we're closely looking into what's actually happening in psychotherapy sessions through audio and video recordings. And I primarily focus my research on rupture repair processes, as well as therapist adherence and competence. Through the Horst Kächele guest professorship, I had the opportunity to participate in Professor Muran's classes and to collaborate with him on several research projects on rupture repair. Today, I want to give you a brief overview on one of my doctoral projects, the 3RS project. So for this international project, I'm collaborating with Professor Chris Muran at Adelphi University in New York, as well as Silke Andreas at University Klagenfurt in Austria, and Christoph Flückiger at University Kassel, and Wolfgang Lutz in Trier, so they're both in Germany. For the 3RS project, I recently received funding through a small research award by the Society for Psychotherapy Research. So the project focuses on assessing rupture repair in psychotherapies. And for this, the rupture resolution rating system, the 3RS that was just mentioned, is the best observer-based measurement. And recently it's been revised into 3RS version 2022. And this project aims to establish the reliability and validity for this revised version of the 3RS, especially in its application to audio versus video recorded therapy sessions. So here you can see where the name 3RS AV project comes from. So it's audio versus video. But before I will go into more detail on the research strategy, I would like to just give you a brief overview or reminder of the rupture repair concept. So Chris Muran and his colleagues have been researching rupture repair processes for more than 30 years, and they've done extensive theoretical as well as empirical work, and they demonstrated the clinical significance of rupture repair in a variety of studies. And there is a growing body of research on rupture repair as a critical change process for psychotherapies. Alliance ruptures are defined as deteriorations in the alliance, and they are manifested by a lack of collaboration between patient and therapist on the goals or task of therapy, or a strain in their emotional bond. Fundamentally, they are co-constructed by patient and therapist, and they can be organized into two subtypes, so withdrawal ruptures and confrontation ruptures. Ruptures can be severe breaks in the alliance, but they can also be very subtle, and they are quite prevalent. Ruptures occur in all therapies, and with therapists of all skill levels, they are inevitable. And if not resolved, the frequency of especially confrontation ruptures predicts dropouts from therapy, and they are linked to lower therapy outcome. A repair process, on the other hand, enables the patient and therapist to renew or strengthen their emotional bond and to begin or resume collaborating on the tasks and goals of therapy. And repair strategies like exploring the rupture are interventions that are used to repair or resolve the ruptures. So to conclude, while ruptures that are not resolved pose a threat to therapy and predict dropouts, a successful resolution can actually deepen mutual understanding and improve therapy progress. And it's also related to good therapy outcome. So onto the rupture resolution rating system. That's the most widely used observer-based measure of rupture resolution processes in psychotherapies. And the recent revision aimed to address previous shortcomings and to allow for a more relational conception that is in line with the relational focus of the rupture repair framework. And that is to include both patient and therapist contribution to ruptures as well as repairs. And the working together subscale was introduced as an alliance assessment before assessing for potential ruptures and their repairs. The 3RS manual recommends application to video recorded psychotherapy, as they offer the most comprehensible data. So facial expression and body language are quite helpful to identify ruptures, especially withdrawal ruptures like masking feelings. And as a side note, right now I'm working on the German translation of the 3RS version 2022 manual. And to assess rupture repair processes using the 3RS version 2022, raters watch a therapy in 5-minute segments, as you can see here in a small example of the rating sheet. And then they rate how well patient and therapist work together, if any withdrawal or confrontation ruptures occur, and whether there were attempts to repair the ruptures. And they rate this on a 5-point scale. So that's the blank spaces in the rating sheet there. Okay, so after this brief overview, I want to get back to the research project. Since the revised version of the 3RS was introduced very recently, it needs further investigation regarding its reliability and validity. And while the 3RS is an observer-based measurement used to identify rupture repair in video recorded therapy sessions, psychotherapy studies often audio record sessions due to data protection or limited resources. And so far, first attempts of applying the 3RS to audio recorded therapy sessions have been promising, but a more systematic investigation of the application to video recorded versus audio recorded therapy is necessary, so that the 3RS can be actually applied to a wider range of psychotherapy research. And therefore, the aims for the 3RS AV projects are to firstly directly compare the 3RS V 2022 ratings of video and audio recordings of prospective sessions to establish the reliability and validity to then apply it to audio recorded therapy sessions. So we're doing this to investigate if there are any significant differences between ratings that are based on audio recordings versus video recordings. So we're basically looking at what we're missing when we're rating only based on the audio. So we're not able to see facial expression and body language. And in the second aim, we're exploring the convergent validity of the 3RS version 2022 subscales. So the working together subscale rupture and repair by relating them to the post-session alliance scores. And if successful, this study would establish the 3RS version 2022's reliability and validity in application to audio recorded therapy sessions, and therefore would be able to apply the 3RS to a wider range of therapy studies and psychotherapy process outcome research in general. And this would allow for further investigation of rupture repair in studies that audio recorded the therapy sessions due to patients and therapists' data protection or limited resources. And this in turn, of course, would enable further research that provides clinically useful data, like what to do when a rupture occurs. So now I'm briefly going to tell you about the collaborative sites and the methods in this project. So for the 3RS AV project, our data set will consist of 46 patients from Trier, Zurich, Klagenfurt, and New York. And the patients were treated either with cognitive behavioral therapy, psychodynamic therapy, or brief relational therapy. And we have process and outcome data available, as well as video recordings of all sessions for all of these patients. And through the collaboration, we're able to diversify our sample, as we're including patients from 4 countries treated with 3 different treatment approaches in 2 different languages. And for each of the patients, we're selecting 2 sessions from the mid-phase of their treatment by performing targeted session sampling. So that's what you can see in this nice picture here. We're applying control charting to the post-session self-report alliance scores. And we're doing this to identify V episodes. And V episodes are characterized by a high, low, high pattern. So that's what you can see where the arrows are pointing at in the alliance scores. And they may indicate a rupture repair process. So in this case, we would select the second and third session as a proxy of a rupture and then a repair process. And after selecting the sessions, a copy of the video recordings of the session is converted to audio-only recordings, and then a set of both the audio and video recordings is available for all of the 98 sessions we selected, because it's always 2 sessions for each of the 46 patients. And to assess inter-rater reliability, 50% of the sessions will be double rated. And a set of randomized sessions with equal parts video and audio recordings is assigned to all of our raters. And there are 3 teams of trained raters from IPU Berlin, from Trier, and from New York who will apply D3RS to these sessions. And just quickly about the analysis. So inter-rater reliability will be assessed utilizing intra-class correlation, so ICC, and then primary analysis will address aims 1 and 2. And given the nested and repeated measures nature of our data, we will apply a generalized estimating equation regression method. And for aim 1, we plan to relate the D3RS V 2022 ratings of video and audio recordings of the respective sessions, both on the 5-minute segment level and on the session level. And to address the second aim, we plan to relate the D3RS subscale, so working together, ruptures and repair, to the alliance scores. And in secondary analysis, we will explore possible effects of geographical location, treatment modality, and spoken language, also with GE. And just to give you a quick idea of where we're currently at with this project, right now I'm in Klagenfurt, and my colleagues, Nicolas Lou and Levin Laza, we just finished the first part of the D3RS ratings. And yeah, with this, I'm going to end my presentation. So thank you very much to the IPU for giving me the opportunity to present this research project to you. And special thanks to Chris Moran, Wolfgang Lutz, Christoph Lückiger, and Silke Andreas for collaborating in this project. And of course, to the raters who are doing an excellent job in this very time-consuming effort. So I'm very much looking forward to the next presentations and our discussion. And thank you very much for your attention.
Yes, hello, everyone. I'm glad to be here today. My name is Sofia Kontaxi. I'm a PhD student at the International Psychoanalytic University today. The project that I'm proposing today carries the title Individual Differences in Primary Emotional Systems in Humans and Emotional Motivational Processing in the Brain. And the project is located at the intersection of cognitive neuroscience, neuropsychoanalysis, and personality psychology. And the neuropsychoanalytic part of that project is based on the work by Mark Solms and refers to the context of the project as it aims to contribute to the revision of drive theory. In this project, we aim to combine behavioral and neurophysiological methods in healthy human individuals to validate specific aspects of Panksepp's affective neuroscience theory. Jaak Panksepp was a neuroscientist and psychobiologist who postulated that there are 7 primary emotional systems deeply embedded within the mammalian brain. And each of these systems, each one of these neurostructures can be evoked by stimulating distinct but partly overlapping subcortical regions of mammalian brains. we have, as you can see on the slide, some positive and negative systems. So the positive systems are called seeking, lust, and care, and the negative systems are called anger, fear, and sadness. These Panksapien affective systems can be explained in the context of nested hierarchies of affective processing. And here on the left side, we can see a schematic representation of what is meant by that. This two-way or circular causation can be explained from primal emotional functions. So those affective systems refer to those red rectangles, those primary process emotions deeply embedded in subcortical regions of the brain. These influence secondary process learning, such as classical operant conditioning and memory mechanisms. Both first and secondary processes intersect with tertiary process cognitions. And here we are talking about processes such as intentions to act or reflecting about one's own past, for example. On the other hand, top-down processes such as cognitive regulations and learned control intersect the other way. And looking at the subcortical primary processes, this is especially relevant for the understanding of mental disorders such as depression or panic disorder. But the effects of primary emotions on a tertiary level can also be relevant for understanding individual differences in non-clinical populations by examining direct responses to motivational and affective cues and higher order motivation and cognitive modulations. With this theoretical background, I would like to give a short overview of this project. We'll get to some of the details more in the next minute. So the general aim of this project is to examine individual differences in primary emotional systems, focusing on seeking, sadness, or rather panic and grief, and to contribute to the individual variability of emotional and motivational responses as a basis of personality and variations thereof. In a first step, we plan on assessing primary emotional systems in a sample of 100 participants. This will be done by using a questionnaire that has been developed based on the affective neuroscience theory. In a second step, while focusing on panic, grief, and seeking, we plan on correlating these questionnaire systems with brain states. And this will be done by applying electroencephalography, also in 100 participants. And we will use a paradigm that allows us to examine attentional modulations with emotional and motivational manipulations. And therefore, we will be able to look at high and low affective states of panic, grief, and seeking based on the questionnaire assessment and their associations with event-related potentials in the EEG. Out of this EEG sample, 50 participants are planned further to participate also in an fMRI study. And here we plan on looking at neurolocus of all the panic, grief, and seeking systems from a functional perspective. Of course, here it's still an open question what paradigms are useful for that. So for panic and grief, experimental manipulations of social exclusion are reported to be very successful. And for seeking, experimental manipulations of performance feedback seem to be sufficient. So now going into the ANPS assessment, in order to integrate the ability of humans to report their emotional experiences related to these basic emotional responses, and to assess really this individual variability, a self-report questionnaire has been developed, which is based on the affective neuroscience theory. It's called ANPS, the Affective Neuroscience Personality Scales. And the current version, 3.1, includes 7 emotional states. You can see them listed here. The ones I would like to refer to mostly here is the seeking system, as it is the appetitive, exploratory, investigatory system. And that is especially essential for acquiring all the environmental resources we need for survival. The sadness system, as it's a focus of this project, is a little bit more complex. During the sadness system, or when the sadness system is evoked, in separation distress situations, it is divided into 2 phases. The first phase is a panic phase. And here in this phase, individuals are trying to reunite with their attachment figure when being separated from them. So when we're thinking about baby animals, they start running around crying for their mom. And after a certain time, when this reuniting with the attachment figure is not being achieved, what we perceive as some kind of shift with the downregulation of the seeking system and a grief phase, a depressive phase starting. Here in this despair phase, it's especially characterized by loneliness, wandering around stops, and the individual has lost any hope of being reunited again. Since these two phases have never been separated before, but have always been proposed together as the sadness system, in this project, our first step was to separate panic and grief from each other into panic and grief subscales within the ANPS. And during this revision, we not only divided panic and grief, but also included a last scale that has been missing for a very long time, looking at the literature of the ANPS. For this extension, it was important for us to look at panic and grief in their association to the seeking system. While in panic, seeking is still high because we have a pro-death phase that is very highly correlated with a lot of action, calling, wandering around. The grief state, the despair phase, is characterized by a down-regulation of the seeking system. So while we're having in panic a high seeking, in grief, it's a low seeking activity. And for this separation of panic and grief, going too further, we had to formulate further items for those scales. You can see some examples that we came up with on the left side for panic and grief. Each scale consists of a total of 13 items, with 5 of them being inversed. So for panic, it was important for us to formulate items that in here, the ability or the need, the feeling of preventing separation, trying to prolong it for a certain period of time. So when I haven't seen my family for a long period of time, I feel a strong urge to visit them, or I always try to be on good terms with my friends. But for the grief system, it was important for us to integrate items that refer to feeling sad, lonely, and being left alone. From a first data set that we collected with 75 participants, we were able, from our first analysis, and this is what you can see here from our principal component analysis, when looking at the distribution of those items, we did find 2 separate factors, although, and this you can see with the green and blue dots on the right side, they still show some kind of overlap. So it's not perfect yet, but the overlap is not too big. So from here on, we're good to go with our study. So coming back to the general overview, this is the current state. We'll make some minor further adjustments within the next few months to the ANPS items, and then we will further go the step into the EEG. Here, we plan on using specific manipulations of a paradigm that has been used in our research group before. It's called the choice paradigm. And then it includes conditions of self-determination by applying certain motivational manipulations. So for example, participants are able to choose the category of pictures they're about to see. They seem to feel more motivated when they're able to choose the picture they're about to see. Of course, emotional manipulations, and here we're still looking at correlations also to panic and grief and event-related potentials. This can be inhibited by adding emotional or affective significance to affective pictures. So we're looking at pictures, if they're negative or positive, this enables us to go further. And for the seeking system, as mentioned previously, the aspect of intrinsic and extrinsic manipulation is important. And here, especially feedback processing can inherit this. So for the event-related potentials, it will especially components such as delayed positive potential, the LPP, we will be looking at for effective and motivational modulations of attention. And then coming to the fMRI study, it is important to say here that out of the EEG populations, you may have seen there's 100 for the EEG and 50 for panic and grief for the fMRI. We intend to form groups to compare, which include people with high panic and low grief in one group and low panic and high grief in the other group. And based on this first data we collected, we do take into consideration that in order to test the same participants in the EEG and the fMRI, it might be necessary to pre-select certain participants already for the EEG study based on their panic and brief score, because the high variability in a randomly selected EEG sample might not provide 50 participants for the fMRI study. But this is a problem to be solved, and so far we got. And with this, I would like to end my presentation. Thank you very much for your attention, and I'm looking forward to our discussion. Thank you.
Hello again, and thank you very much, Mr. Hamburger and Mr. Olbertz, for the introduction in the beginning. And my name is Marie Siebert. I'm a doctoral student and research associate of Christiane Steinert at the IPU. And with Heidi's visit, and also with the start of our project, I had the chance, and have it still, to dive deeper into the qualitative research. And I will show you this in a minute and just open my slides. And starting with a quote, then you should really jump from the high dive. In our project, Participation, it's called, it is a big interest for us to ask the patients for the patient's experience. Like this sentence comes from a study participant who went through a trauma-focused psychotherapy with partly confrontational parts. And doing psychotherapy is often something very different than originally thought. And as a primary goal for us to serve like individuals, but also communities living with or also at risk of mental illness or disease, we want to hear their voice and to learn from the experts by experience, as Jessica Schleider 2023 wrote. And there is the fundamental need, there we are, of lived experience perspectives in developing and evaluating psychotherapies. And for this reason, because of that need, our principal investigators, again, Christiane Steinert and Falk Leixenring, have started the qualitative add-on project Patient Participation as part of ENHANCE, which is one of the largest RCTs for PTSD related to child maltreatment with over 350 patients right now. And also we're conducting it in a team, and you can see all the names of the remaining team members on the bottom of the slide. But maybe you're asking yourself, why qualitative methods in psychotherapy research? What are the arguments? And shortly, we want to capture the lived experience and change processes to develop contextualized descriptions and understandings. Thus, we try to contribute to a more comprehensive understanding for the research object by combining different epistemological perspectives. And furthermore, we're conducting this kind of methods to unveil new aspects that are not asked in quantitative studies. And also an important aspect is, as a reflexive science, we want to recognize the investigator's own subjective assumptions, like my own. But what we do exactly in our project in patient participation, as I already mentioned, our study is part of the ENHANCE study, comparing two trauma-focused short-term therapies on which our data is based. And quotes like the following guide our research interest and also our questions. So the first one, for example, sometimes I was really afraid that I would mark something wrong in the questionnaire. Or second, and this experience is just exactly the same pattern as when it happened before. Third, I think it was very helpful for me to be able to process it again through this conversation and to see what actually annoyed me about it. And quotes like that result in projects that ask, how did patients experience participating in an RCT? Or second, which Latin meanings or non-verbalized, non-verbalizable aspects and unconscious dynamics turn up in the post-interview? And third, what are the helpful or not helpful aspects of the intervention identified by the patients when we are asking them? And how we do answer these questions. For our data collection, we are currently conducting semi-structured interviews, and we use the translated and also quite modified version of the client change interview by Elliott and Rogers, and it's an ongoing survey. Right now we have around about 45 interviews, and we decided on 3 analytical approaches as different questions require different methods and ways of answering them. So for the first one, we try to answer the question about the study experience via your critical constructivist grounded theory approach, dear Heidi. The second one, where we question for the latent meaning in the context of the RCT, like the unconscious dynamics. There we use a convergent mixed method design where we're combining the one side a depth hermeneutic analysis and the evaluation of the quantitative outcome data, which is of course a measurement for PTSD in our study. And for the third question, where we try to identify the perceived helpful or even unhelpful aspects of the intervention, we use a qualitative content analysis and try to prove a meta-analysis from 2022 by Ledmanova and colleagues. And for a little insight in our data collection, because this is the base meant, I just show you an excerpt of the climate change interview, like the English version of 2008. And here you can see, for example, the question asking for helpful aspects. Looking back on your therapy now, what would you say was helpful about your therapy? Please give examples. But you're also interested, like in the other talks, what we already found out, like what are our first findings. And very important, I will show you an analysis that was primarily conducted by Irene Fechau, and many thanks for providing these insights for us today. And you remember maybe research question number 1, ask for the study experience, and where we had chosen Heidi's grounded theory approach. And the yet unpublished results show us that the study setting, like the context, the RCT, arouses positive and negative fantasy at the very beginning, like at the start of the study, of the participation. And this we have called cluster number 1, fantasies. And here you can see wishes and positive assumptions that motivate patients to participate, and above all, category number 1, the hope of a therapy spot. But there are also fears and anxieties about the participation, most prominently the fear of not being accepted and the fear of confrontation. And in grounded theory, there's often, but not always, a core category. And our core category is called fitting in or not. It shows us a kind of field of tension. And there's this fundamental ambivalence, like asking yourself, how much can and must I adapt to external circumstances and demands, and maybe even thus overstep my own boundaries? What kind of performance do I have to provide in order to be allowed to receive something good for myself? That are questions that came up like when we just screening all the interviews for this study. And yeah, I'm pleased to be able to show you these insights today, and want to end with a quote. Now, for example, this interview situation. So even if I found it mega sad when I talked about it, it is still a good feeling for me that I can talk about it again. I like the idea that you have the possibility to improve things yourself as a participant. Thank you for your attention, first of all. And of course, thank you, Heidi, for your insight and your creative and instructive approach last year to qualitative science. And Christiane Steinert, of course, thank you also for your support.
So thank you very much, Marie, and all the three of you. That was really a wide spanned field of research, be it in the fields on the content of the research, but also methodologically quite some global thing. And if you remember our general topic of pluralism in research in psychoanalysis, I would just invite our guest professors now to comment, maybe keeping in mind that you could, if you like, to relate to the general question, what the hell could all this do good or be relevant?
Maybe since I'm unmuted, I'll Heidi, did you want to start or?
No, you can begin. I'm happy to follow.
Okay. Maybe I'll work backwards, because I love pluralism, but I'm also very structured too. So they were all really, really impressive presentations, and obviously I know Jenny's more intimately. So this was an opportunity to see what Sofia and Marie were doing and having a better understanding. And usually whenever I discuss things, I end up asking questions more than anything else. So, starting with Marie, I mean, it's wonderful that you have this rich data set and you can apply qualitative method to an effort that has many quantitative measures. So my question, though, has to do with to what extent are you really going as far as you can with mixed method? So in other words, you have these interviews, but you also have a data set where you can, I assume, and this is a complicated question, but you can actually sort the cases in terms of outcome in some way. And it's complicated because I don't know what outcome measures are in play. Some outcome measures may be more relevant to the qualitative data. So, but I was curious whether you are organizing it in that way and then looking at the qualitative data accordingly, if you follow what I mean.
Thank you very much for this question. Yes, that is something we already thought about. After this research question, I presented it to you today to do more of this mixed method approaches, because it's quite a chance to have this huge study, this RCT with different measurements and from different perspectives. And of course, it's quite interesting to, for example, combine a sample of patients, for example, the non-improver or the people that really improve when we call improvement like symptom reduction, that's also a discussion we have to talk maybe later on. But to combine a sample of them with the interviews and looking what happened over there during the therapy. How can we interpret these numbers? And yeah, this is one example we can do. They're pretty other questions, like we have measurements of mentalization, reflection, functioning, like you ask what is maybe also a bit closer to qualitative methods than just symptom measures. But yeah, this is important there.
Yeah, so I would really encourage going the distance. You can you can now go back and take more advantage of the quantitative measures. And yes, obviously be, smart about which quantitative measures and, measures regarding emotional insight might be more relevant. But, you could play with both, and I'd be interested to see if you do find any differences in the qualitative data with respect to how you organize the cases by outcome. So that was my big question. Sofia. So this is an area I'm less comfortable with, although I am very interested in emotion and the research on emotion and also what the neuroscience can tell us, but certainly I haven't done this kind of research. But so my questions might be a little rudimentary, but so first I'm curious, and I've been asking emotion researchers and neuroscientists this question a lot, is how do you accommodate this? Because there is this movement now about constructed emotion, and Lisa Feldman, Barrett's work, and whenever I see work that's trying to build on primary emotions, I'm curious in terms of how you're thinking about this other perspective. So let me start with that question first, and because that's kind of a big one, and I'm curious where you're at and maybe where Mark's at with that.
Yeah, that's a very difficult question to begin with, to be honest. Yes, there are those two streams in cognitive neuroscience or emotional neuroscience, referring to the localizational and constructive approach. Of course, there seemed to be a lot, and you're referring to Lisa Feldman Barrett, her doing a lot of work and putting a lot of effort into researching those specific networks of emotions. The Panksepp theory, though, there's strong evidence for it still. And what it provides is also reflecting on at which time in the course of evolution, which part of the brain has evolved. And so when we're looking at those brain regions responsible for the affective systems as carved out by Panksepp, we're in the very old part of the brain. And we can see that especially these regions are responsible for other types of emotions, so that the seeking system is also responsible for the care system and so on, that this area triggers the others, and that other emotions such as feeling guilt or shame are more localized within the neocortex of the brain, so a different area. And it's a difficult approach. There's no real answer to which one is the right theory, I'm afraid, but it's always relevant in the context of it. And what we see in Panksepp is especially as they serve as emotional needs, when especially patients are coming into therapy, these are the feelings they are suffering from and the needs they are having, and referring to those needs, it helps a lot in the therapy. Yeah, I'm afraid that's the best answer I can give.
No,
so
that's
far.
good. And I always, when you do publish your work, I mean, it'd be good if you could at least build a little bridge or acknowledge this other area too, so that people keep talking to each other. Another question I have is, which is receiving a lot of attention in clinical practice, is the question of emotion regulation, not just emotion generation, but emotion regulation, and it's becoming a very topical transdiagnostic process now that's being addressed across different cognitive behavioral, humanistic, psychoanalytic. And so I'm curious in terms of like what this work can say about emotion regulation and its relevance for psychopathology and clinical practice. Another hard question.
Very valid and very interesting. Yeah, I think when I heard your question, I was thinking about the schematic representation again that I was showing in the beginning. And as it shows those primary, secondary, and tertiary levels. And of course, emotional regulation that goes backwards from tertiary level back to secondary and primary processes. So this is something which also is part of the whole process and has a very important influence also on primary processes. Of course, the way they are carved out, those affective systems, by, for example, genetics and other predispositions that we have made in our early childhood experiences, they carve out those affective systems. But on the other hand, emotional regulation strategies can help to deal with these kinds of feelings that we have, although they will never disappear. We will always have a need. But emotional regulation is a helpful mechanism also in therapy, of course, in that whole course. Yeah.
Well, so similarly, if you could address that in the products of your work, even in a small way, because clinicians will be curious about that. It is receiving increasing attention now, and so it's not only transdiagnostic, it's trans-traditional, theoretical, and its relevance. The last thing I wanted to ask about is, in terms of the principal component analysis of the measure. Now, did you? It went pretty quickly, so I didn't know if that was based on someone else's research, but was that based on someone else or a PCA that you conducted?
This is a PCA that we conducted indeed with the data, first pilot data that we collected. That is true. Okay. Yeah, it's been.
And so, do you know when you did the analysis? Was it based on an orthogonal rotation when you did?
Yes, we did apply the Verimax rotation. We looked at both unrotated and rotated matrices, and yeah, but the one that was shown here was the rotated one. Yes,
which is the orthogonal one, not. But you did explore an oblique rotation, is what you're saying? Because I was sort of curious. Did you really conceptually? Did you really think that the factors would not be correlated, or would you expect some correlation among the factors?
Yeah,
and therefore an oblique would be a more appropriate rotation.
Mm-hmm. Yeah, the rotation, that's a very valid question of which rotation might be the appropriate one for the research question that we're following. I mean, right from the conceptual level of panic and grief, there will always be an overlap with them, as they're both part of the sadness system. They're partly to be regarded as subscales of sadness, so to say. So a complete overlap will never be achievable, but our aim is to separate them as good as possible as we can do it, because one has to go through panic first in order to get to grief phase. And since all of the system always interact with each other and those phases are fluctuant, one can go from panic to despair and back and forth. Some overlap will always remain.
So my apologies to Heidi, but I can be a quantitative nerd. So, and I do think when people do factor analyses, they tend to reflexively just go, Verimax orthogonal. And again, like whenever we do any strategy, it needs to be thoughtful and it needs to fit the concepts. Not that you'll get a hugely different result, but anyway, that's my last comment. I'm not going to comment on Jenny. Oh, I'll just say one thing about Jenny. I mean, there's a lot. Jenny's effort is in some ways has such a rich potential. It is really foundational. There are a lot of issues to address here in terms of video versus audio, English versus German, or so there are a lot of critical factors to address, and that's just gross. There are other issues. There are all these other differences in there that we'll be navigating. But I'll stop there and leave room for my colleagues.
Thank you.
Yeah, thank you. And thank you to the 3 students. I have been continually impressed by the work that's being done at IPU, and the work you're doing, it shines, and it's really exciting. Super happy to get to hear about all of the projects. And I will start then with Jenny. And I loved learning about, I've done process research. I haven't done a lot of alliance-focused research, but I loved learning about the V shape as a way to identify moments that might be bearing further and deeper exploration. And so that was really interesting to me. I was wondering, as I was listening to you, because you're doing a comparison between CBT and 2 more relational oriented therapies, I was wondering what you're expecting, or what you're beginning to see as you're doing your analysis.
Thank you very much for the question. So far, we haven't done the CBT ratings, so we don't have any, haven't done any analysis yet. And actually, I don't think we have any really solid idea of what the differences would be between the different therapy approaches, because I don't think that's really been investigated in a big comparison, like comparing CBT and psychodynamic. What we can definitely tell by now is that therapist effects are definitely a thing. Also in our very small sample that we just rated here in Klagenfurt. So maybe that's way more important than the approaches by themselves. And I guess because we're doing the controlled charting, we're trying to max out the opportunity to find a lot of ruptures and really good repairs, so that there's not just a session where they're doing great therapy and we can just see them doing the interventions. But we're curious to see that what we might find. It would be good, like in an ideal world with more funding, we would of course have a bigger sample and also include other therapy approaches like systemic therapy in Germany, because that's also funded by health insurance. And hopefully we can do that in the future. But right now we're trying to get the 3RS or investigate the application to audio sessions, because there are a lot of cool studies that we would love to apply the 3RS to. For example, the APD study, so that's anxiety and personality disorder. It's a very big study, and they recorded everything on audio. And that would be lovely to apply the 3RS in that study. Yeah. So we would love to in the future look at different treatment approaches and also specific to different diagnostic groups in a way, like personality disorders.
Yeah. Awesome. And I guess the last question I was wondering about as I was listening was the training, because I think sometimes people will identify as a CBT therapist or as a brief relational therapist, but it may be unclear, like, have they had specific training in working with alliance ruptures or not? I don't know if there's any questions or if there is any data, but if there is, it would be fascinating to look to see, like, people who identify as CBT, if they've had alliance training, does that make a difference or not? I don't know. I'm not sure if you're collecting any data on training or people who are integrative in their training, had training across approaches versus not. I don't know.
So about the therapists in our project, we just, like, the CBT therapists, they were both in the groups are based on RCT samples. Mm-hmm. So we know, like, very detailed about their training. But Chris did a study investigating adding alliance-focused training to a training course for therapists. But that's like, we can't really investigate it in this small project. There would have to be another one.
Yeah. All right. Well, it sounds like it will be very exciting to hear your results. I'm looking forward to it.
Thank you.
Sofia, I really enjoyed hearing about your study, and I am coming from listening to it from a emotion-focused therapy perspective. And so as I was listening to you, I was wondering about whether, it sounds like, and it was hard for me to tell if you are looking at this or not, but I was wondering about within this differentiation between panic and grief, right? Sometimes the emotions could be adaptive and sometimes they could be non-adaptive. Like people could have complicated grief where they are not moving on from their grief and it's stopping to be an adaptive emotion for them to keep processing. Or sometimes people might have experience of panic, which is enduring and keeping them from being able to move on to experience the grief at all, or in a deep way, or to move to some resolution. So I was wondering if what you would think about, or if it sounds like you're doing this really unique work of separating out the panic and the grief, right? And so wondering if you're thinking about like, when are these things adaptive or non-adaptive for people? And just thinking about the motion-focused therapy ideas of primary adaptive and secondary maladaptive emotions as like maybe being helpful if you're interested in thinking about that process of not just what emotion is being experienced, but is it helping or not helping someone?
Thank you very much for that question. That's a very interesting aspect you've mentioned. The separation of panic and grief from a conceptual level coming from PANCSEP seems to be very clear, but as you're saying, panic and grief themselves are very, very complex processes happening. So speaking from a grief phase or panic phase in a larger context, and especially in emotional therapy, is not sufficient enough because there's a lot of happening. It would be very interesting to look further at the functions of these emotions in a broader sense in other therapeutic contexts. But for now, of course, in our project, we're already busy finding them in the brain. And of course, for this, it would be very helpful to validate the ANPS questionnaire with the correlations in EEG and fMRI, but then go the step further from tertiary processes back to primary process and see really the effects. But of course, in order to find those people who are high in panic or high in grief, according to the ANPS or the affective neuroscience theory, we need the questionnaire first and be sure that it's good enough to find the subjects that we can then further study. So I would keep definitely in mind what you said. It sounds interesting, very interesting.
I'm really excited too to hear what you end up with, right? It's awesome.
Thank you very much for that aspect.
Marie, so nice to see you again and to hear about your project and how it's been evolving, right? Since I talked with you last. As I was listening to your results, I was, loving the idea of fundamental ambivalence and how your work is really drawing attention to how RCT methods structure certain kinds of findings and limit or prevent other kinds of findings, at least within the context of those studies, right? And it reminded me of I don't know if you know Femke Truigens and Melissa de Smet's work. They have the series of papers that are like playing on Thomas Nagel's "What is it like to be a bat?" paper, where they are like, what is it like to be the object of research, right? And I feel like you're sort of doing a similar thing. Like, what is it like to be in one of these studies where you're being asked to answer certain kinds of questions and to respond in a certain way about your treatment experience. And that may be not letting you, respond about your whole experience, right? And the ambivalence that someone might feel when they're wanting to provide information about their treatment, but they're methodologically restrained, right, in certain ways. And so I thought that was really, really interesting. And so I was just excited about this core category, and I guess curious about, I don't know how you're doing with, because we got a little bit more about question 1, right, answer, but curious about questions 2 and 3, like if there's things that are coming forward that you might want to share a little bit about, but yeah.
Thank you, Heidi. Yes, maybe I should start with question number 2. That was the question about the unconscious dynamics. And right now we kind of finished our analysis, like this depth hermeneutical analysis combined with the outcome measurements, like this is a CAPS, PTSD measurement, a clinical interview. And there we found this slogan, the hermeneutics in the numbers, that you have this number at the end, like a 5 or 40, and then you have to interpret them. Like, what does it mean? Is this just a reduction, or what happened over there? And we found out that sometimes when there is, for example, an idealization of the therapy, and that is really hard in the interview and the post-session interview to maybe allow that you still have some symptoms, because this means that the therapy and your therapist was not perfect. But there you made, for the first time, maybe a positive relational experience. And you have the feeling that when you now criticize this relation or this therapy, that you will destroy them, or destroy this, most of the time, short experience, like we're speaking of short-term psychotherapy. And that's it's a bit more complicated, of course, but in short, just how we're coming to a number at the end is very intertwined, like connected with things that happened in the therapy. And yes, sometimes they're meaning also something else, like as in defense or to protect something. This is just a glimpse. Yeah. So what was do you have another question?
I guess my other question, I just was wondering about the questions, the 2 questions that we didn't hear as much about, the helpful and unhelpful. I guess I don't know where you're at with that, or
right.
Research
question number 3, or I don't know the raw, where we asked about the helpful or even unhelpful aspects. There we try to prove if the results of a meta-analysis by Latmanova and colleagues of 2022, they found out 12 categories, 12 that are helpful, for example, relief, etc., like having insights during psychotherapy, or what else we found, it like developing, of course, new skills and coping mechanisms, that all these categories they found out. We tried to prove then if we will find it again in our transcripts and our interviews to check. This is the deductive way. We have categories and we will check, oh, cool. There was a meta-analysis about different orientations and different therapies and people. They found out this is helpful. We'll find this again at post-treatment. the meta-analysis was at post-session. Every session they filled out or were asked for what was helpful, what was unhelpful. And now we also combined it with an inductive way of going through the text and looking what other aspects, and that is the creative part, new aspects in our specialized psychotherapies, like we have a CBT, stare narrative therapy, and a trauma-focused psychodynamic therapy. Are there new aspects that are not captured in this meta-analysis? Yeah, so this is the way we try right now. It's ongoing to answer this question about helpful and unhelpful aspects.
Awesome.
Okay, many thanks. I think we should move on to Mark Solms' questions and comments, because we are a little late in time already. I have the gatekeeper here. And yeah, it's really interesting. Mark, please.
Considering your last remark, Andreas, how long do you want me to stop by a particular time point?
We all are already over the time, so just
okay. So then I'll be very brief, and I'll change the order of the students, starting with Sofia, because she's the one who's not been begun with yet, but also because Sofia is the student that I've had the most to do with. So I want to make some comments about her study rather than ask her questions, because obviously any questions I've had, I've asked her and interrogated her many times before. And then I'll make much briefer remarks about the other two. I want to start with Chris's question about the other approach. And just for those who are not entirely sure what Chris was talking about, there are really two completely different schools of thought about emotion nowadays. The one is the one that Sofia's working within, which is broadly speaking called the basic emotion approach. And the other is the one spearheaded by Lisa Feldman Barrett, who was mentioned, which is the constructed approach. The idea of the former approach is that we are born with innate categories of emotion, that everybody has must deal with the feelings to do with lust, feelings to do with rage, feelings to do with fear, feelings to do with separation distress, which is the focus of Sofia's research, and that these are natural kinds. You know, they are different from each other, and they are obligatory, that none of us is exempted from them. Whereas Lisa Feldman Barrett's approach, the constructed emotion approach, is that there's no such thing as natural kinds of emotion, that we construct concepts, and these concepts are idiosyncratic. We each have our own way of understanding our emotional experiences, our ways of passing them, and that those ways of passing them are determined not only by individual idiosyncratic aspects of development, but also by social forces, by cultural forces, and so on. So that's what the issue is all about. I've recently had 2 long debates with her, about these 2 different approaches. So anybody who's deeply interested in that question, just Google our names and you'll find the YouTube discussions about it. But as it relates to Sofia's research, this is the main thing I want to say, is that it is in some respects a false dichotomy, the dichotomy that I've just been speaking about, because the people working within the basic emotion tradition, they fully recognize that over and above the basic natural kinds, there's socialization, enculturation, individuation, and so on. And so what Sofia is calling tertiary processes. That's what you end up having. You have these things that you think about and things that you've learned and your own individual experience, which interacts with these basic natural kinds. The level of research that Sofia is doing is at the level of tertiary processes. It's therefore stacked in favor of the constructed approach, because the evidence for the basic emotion approach comes mainly from the rodent brain, where you can really poke around and find what are the circuits and what happens if you stimulate this, what happens if you stimulate that. When it comes to human beings, we are much more tertiary level creatures, and you can't do that kind of research. So the evidence in human research is much more stacked in favor of the constructed approach. Now, Sofia's working with human beings who are reporting on their own emotional states, and so she has to, as we have to, unless we can open up the skull and start poking around in human brains. This is the kind of research that she's doing. So one of the big challenges that she has is, how do you get from these self-report questionnaires to the actual underlying constructs? Are you sure that you really are measuring those underlying categories that people like Jaak Panksepp claim exist? So against that background, these are the two things I want to say about her study. The one is that this questionnaire, the ANPS that she's started from, it really was not a very good measure, if I may say so, just frankly, So the first task that she had to do was to improve that, improve the measure itself, the self-report measure. And that's an enormous piece of research all by itself. In order to improve our chances of being able to actually validly measure these categories of emotion that at least some of us believe exist. But then the second thing I wanted to say about her study, and this is the main thing, and I'll end with that as regards my comments to her and about her, is that this ANPS, which is very widely used all over the world, and which she's improving, it's never been correlated with actual brain measurements. So we started with animal research, in which it was concluded that there are these 7 basic natural kinds of emotion. And then this questionnaire was developed for humans based on what we'd found in animals. And now what she's doing, I really can't overstate it, is going back to saying, okay, well, say if we can separate these things at the behavioral level, do they in fact map back down to the brain structures that we expect them to? That's a fundamental contribution. And last but not least, it addresses the question that Lisa Feldman Barrett has challenged this approach with. If Sofia finds that there are indeed different patterns of evoked potential and fMRI response to these behavioral challenges that correlate with what we found in the rodents, that will be huge news, and it'll speak directly to the controversy at hand. So that's what I wanted to say about her. Just, it's really a huge piece of work, both in terms of how much work it involves, but also in terms of its potential consequences for this very big debate. Now, I know Andreas is looking very nervously at me, so I'll just make some very brief remarks about the other 2 studies. Mainly I should say I learned something, because although I know a lot about my own field, I know very little about those 2 fields. So it really was just, even though I know so little about it, it was just obvious that this is excellent research. And I know that these 3 studies have not been cherry-picked. These are representative of what's going on at IPU. So, these are really excellent studies. So I'll say something about Jenny as a study. It's coming as a complete outsider to that field. my first question, and I suppose it must be the first question that anybody working in that field will ask, is how do we understand this concept of rupture in relation to the concept of transference? Because, you know, in transference, it's kind of it's almost to be expected that there will be rupture, and that the management of that rupture is the management of the transference. So, you know, are these different concepts, I suppose, is the question. And you don't have to answer it. I mean, I'd be delighted if you do want to answer it, but I think we're short of time. So let me just for now leave that as a question, and then say that I was thinking about that question myself. I was very interested that you're working in the relational, or at least trying to promote a more relational perspective on this question, because there you move beyond transference and countertransference in the modern sense of the word, and you start talking about, well, what is the analyst's contribution? I don't mean in the Kleinian sense of countertransference. I mean in the Freudian sense of, you know, what has the analyst done that has been unhelpful? And so I think that you know, is a separate question from rupture as transference. Then there's this thing of, yeah, and what do analysts do that is not so helpful? I think that that's a very useful thing to be researching. The last thing I'll say about that study is it wasn't entirely clear to me whether you're looking at the same sessions from the people who are rating them purely on audio recordings. Is it the same sessions that are being rated that you're comparing it to? Because you know, if it's not, I think that that's just a little unfortunate, because it would be wonderful to be able to see what is lost looking at exactly the same session material.
Yeah, it's exactly the same question. That's
great.
What I was trying to say with directly compare. And on top of that, there's sessions for inter-rater reliability. So it's not just.
Fabulous. Well, since you have responded to me, Jenny, I want to say, at the risk of embarrassment, I was just amazed. You know, you were the first of the three presenters, and I thought, what is this, a student? I mean, they were so slick and so professional and so on top of everything, you know, and no sign of the stage fright that Andreas had prepared us to expect. So well done to you.
Yes.
Marie, Siebert. Again, I'm rushed. I mustn't say too much. I want to just tell you again, I learned a great deal when I first trained as a psychoanalyst. You know, I started in the neurosciences and then secondarily trained in psychoanalysis. In the 1980s, I was in London. I was training in psychoanalysis. And those days, you know, you won't know this, but those days, I mean, you were probably being born then, or not yet born then. No, I'm sure not yet born then, sure. But we were debating those days, you know, is this a good thing to have research on outcome in psychoanalysis and on person? You know, and when it was seriously debated, and you know, and analysts were saying, you know, oh, no, you can't measure the things that we do. You know, it's a completely reductionist, it's a betrayal and doing violence to the very nature of psychoanalysis and our understanding of psychopathology and treatment. Our way isn't like, you know, randomized controlled trials and so on. And that's for psychiatrists, it's not for us. So it's wonderful to see that what you're doing, because at the time when that debate was being held, I thought, but why does it have to be one or the other? Why can't we do both? That was exactly what I thought as a 20-something-year-old, you know, training as an analyst. I thought, but why does it have to be a choice? And so to see that that's what you're doing, you know, that in a study by Leichenring, which is going to be a completely objective, quantitative, you know, rigorous study meeting all of the canons of you know, RCTs and whatnot, that you are doing this kind of interview and using this kind of method to be able to not denigrate or dismiss the objective quantitative approaches, but to supplement it. And to supplement it, I don't mean with footnotes. I mean to supplement it with the other half of reality, which is the subjective perspective upon upon our subject of study, which is the mind. I'll end with one tiny little comment. I'm sorry, I'm not going to ask you any questions because, as I said, Andreas is speaking about PTSD. Andreas is look at him. But I'll just end by saying the question that you asked, I think it was question 8 at the end, when you asked them what was missing. I want to make a prediction that when it comes to the psychodynamic therapies, what the patients will say is, number one, what was missing is my therapist never gave me advice. They never told me what to do. I bet you that's going to come out as a finding. And the other one is that I wish I could know more about my therapist. My therapist was too coy and blank. And was that really necessary? So that's a half serious prediction. We mustn't be too serious because we've got an hour and a half to go.
So thank you very much, Mark.
Andreas, yes? There's Chris. No way we can, there's so many rich things that are being said. There's no way we can just keep going and respond to each other, or you can say no to me. I'm just asking. Yeah.
I wouldn't allow it for the time being because we have the other opportunity by relating to the clinical vignette. I think that would be concentrated discussion on an example, and that might be helpful. Just let me thank you, all of you 6, for the presentations and the comments, and especially also the cross comments. Commenting to not of the own kinds research projects. The paradigm of the 7 blind Indians standing around the elephant. The essential thing is that the Indians talk to each other, because otherwise they would never find about anything about the elephant. So let me just add a little more confusion by inviting our audience to raise their hands and put their questions and comments, and then this will be about 10 minutes or so, because then we should go into our short coffee break, very short, and then look at the clinical vignette. And Chris, I promise you we can then respond, or you can respond to each other. Now, I think we possibly could continue. And as I said before, we will show you how many minutes is it? It's short, the video clip. I think it's about
about 5 minutes, yeah.
Yeah, thank you. So we will show you a very short clip from a therapy session. And we do hope that all of our 3 research approaches would have a say on those minutes. And after the session, after the screening, we will divide the audience in breakout sessions where they can agree on a terminus that can be then typed into the Mentimeter. You'll see that. Okay, film on.
I'm wondering how you're feeling about how we're working together about this. I mean, I understand that you're trying a lot of things with your wife, it's not working. You also expressed some frustration with our work. Could we talk about that for a second?
Yeah, I just feel like we're not really getting anywhere. Like, I expected a couple sessions and I'd be like set, and it's not that way apparently. And it's just, I mean.
Can you say a little more about what you were hoping for?
I was hoping that you, especially as a woman, would be able to tell me kind of like how to work with another woman. You know what I mean? It's like, I don't know. Like, I've never been great at relationships in my life, but I'm pretty good with guys because we golf together, we talk about stuff, sports, whatever. But women, I mean, it's just a foreign thing to me. I don't get it. It's like, I can never please her. I can never make her happy. She's always mad or upset. We're not talking to each other. Can you give me some information on how to make that better?
So what I'm wrestling with right now is while we can keep talking about things that I think could be helpful, but at the same time, if you're hoping that I kind of have access to the secret key to working things out with your wife, I'm not going to have that.
Well, that upsets me because, pay good money coming in here. And it's like, you want to get answers. I go to the store, I want to buy something, I get it, I bring it home, it works. I come here, I pay money. Things aren't working. It's not getting any better. Like, I'm trying to be better at home, but I'm not really getting the concrete, guidance that I thought I would get here. And it's it's upsetting because, I'm upset there. I came here for like relief and I'm not really getting it. You know what I'm saying? So why is that? Why can't it be, an easier thing to tackle? But I don't want you to feel like, like I'm not.
What just happened? There was a shift.
Like, I'm not trying to like get you upset, okay, or for us to have like some kind of altercation here about this. I mean, that's not helping anything. But I just feel like there's nobody else I can talk to, and when I come here, try to open myself up a little bit.
Yeah.
And it's really hard for me to do that. And I'm not. For what reason am I doing it if I'm not getting answers?
You're laying it all out there.
And I don't want to I understand you're very well trained, you're a professional, all that stuff, but last thing I want to do is alienate you.
Did it feel like that's what was happening?
Yeah, I feel like driving over here, I was pissed.
Yeah.
I'm like, here I go again to see Catherine, and like, what's going to happen? I'm going to drop another $100 or whatever, and I'm going to come out feeling the same crappy way I feel going in. Why is that? If I go see a doctor and I got a busted leg, he sets it, puts it in a cast, and off I go. He fixes it. I guess I need to be fixed, or something needs to be fixed.
And I feel. I'm kind of torn because I feel the desire to fix things, and I do feel a pull to give you a whole bunch of suggestions. But I also think there's something important happening right now, maybe for us to look at. I mean...
Well, when I was a kid, my parents fought a lot. I was around it. A couple times my mom took off. I didn't know if she was coming back. My dad went on a long business trip. We weren't sure he was coming back. It was supposed to be a business trip anyways. And, it was weird. So... It
was weird.
You lose your, your sense of, community, your home, your family. It's kind of weird. It's kind of, scary. That's all.
And that's a scary thing that...
Yeah, who wants to be alone?
And that comes up with your... wife, your fears about where that could go?
Yeah, I don't want to be divorced necessarily, but I don't want to be in a marriage that's just fake and isn't really, I'm not a big intimacy guy, but I know I have failings there, but I think it's worse to go through life by yourself, right?
Well, I think what's important here is you're trying to maintain and build a stronger connection with your wife. And at the same time, you were feeling disconnected from me too in our work together.
Yeah, I wasn't sure I was coming back, actually.
Yeah, and right now as you're sharing with me, I'm feeling more connected to you.
That's weird because a minute ago I was kind of going off about everything.
But even in that,
pushing it away a little bit. So.
Yeah. But you were also being genuine about where you're at.
Yeah,
Okay, now here we are. And we will just, I think, right now go to the breakout sessions. It's very short, just for 15 minutes. And you're trying, in these small groups, try to find a keyword or two or three that you could after that, when we return to the main session, you can type in the Mentimeter thing, and we get something like a picture of what's going to come to your mind, seeing, or what came to your mind seeing this short vignette, which is highly interesting. And then I do think all of the three research approaches that we have represented in this panel will have a say on that, what we have seen. They can just include your free associations in form of a cloud. That's what the Mentimeter does. Okay, just open up the rooms. Okay, I think, are we together in the plenary again? So just to remind you, there was this Mentimeter thing. Please click on the link and put on your 3 keywords that came up in your discussion. It needn't be, it can be, but needn't be an emotional reaction. We also thought of research questions, things to consider, whatever. And we see what Cloud says. And then our panelists will try to connect to the ideas you brought up and communicate via this modern tool of cloud communication.
Andreas, I wanted to ask, was that vignette, was that acted or was it a real live session?
I think it was provided by Chris, wasn't it?
Yeah, it was. The patient was an actor, and basically, what they were given was kind of an idea of what the rupture should be, and then the second directive was then just try to improvise. And they're all, because they're trained actors, their improvising skills were really good. I was very impressed. I actually worked with that actor too, and a few others. And what we were trying to explore was, this is why it's going to be a little difficult for me too, because that's a close colleague of mine. So I have more biases than usual.
Okay.
But so, we were trying to accentuate differences when you change up the therapist. And anyway.
Okay, Tim, if you'd like, you can show us shortly the result cloud of the Mentimeter so that all can see them, and then we will engage in the panel discussion, and then you make the faces visible again. That's better for.
All right, here we go.
Okay, so who of you in the panel would like to comment on the clip itself, on the therapy situation? My fantasy, as I said in our short discussion, was, could we define something like an approach from the 3 respective research traditions and methods to this kind of material? Would it tell us something, or what would the 3 to 6 Indians that we have here around the elephant of this clip possibly say to each other, what they, on their side of the elephant, could recognize?
Well, I'll start. From the point of view of basic emotion theory, the question is, what emotions were we witnessing here? I think that the patient, it's fairly clear, I would be surprised if anybody disagrees, that the patient was angry. It starts with frustrated, angry patient, and that this then evokes anxieties in him. His anger evokes separation anxieties, worries about rupture in the sense of the relationship between him and the therapist ending. So those are the 2 emotions which conflict with each other. The more angry you are with a caregiving figure, the more you are at risk of losing the care of that figure. So I think from a basic emotion point of view, those were the 2 emotions, and we saw them in conflict with each other.
Yes, if I may add to that, I really enjoyed, for me, it was very interesting to watch this part after the shift that the therapist called out. And here, I think, speaking of affective emotions, affective systems, it was also a lot of attachment happening there, and how the patient said he wants the therapist to help him, fix all his problems for him. And I think especially the separation loss, coming back to panic and grief and the sadness system especially, was being acted out with his wife. And I found that very interesting, that he doesn't want to lose her, but the marriage with her is kind of difficult still. And when looking also at the trans femmes, that this is something we also find in the relationship with the therapist as such. That was very interesting for me to look at.
Mm-hmm. I found that as I was watching it, and thinking about methods that could be used to explore something like this, it made me think about task analytic methods, right, which are underlying emotion-focused therapy, and also were really seminal in the rupture repair research process too. And these are mixed method research approaches that are heavily grounded in qualitative research. And in these approaches, researchers look at a session, sort of like a set clip like this, and map what's happening that is helping to resolve, right? Or that is obstructing the resolution of a certain event. And so here we could see, the client coming in with a lot of anger at first, and then we could see this shift, right, to fear coming up. This made me think a little bit about what we were talking before when Sofia was presenting about the idea that emotions could be adaptive and non-adaptive. So with this client, you could see, sorry, my sister. And so you could see here that this client had a very strong anger kind of feeling, and that that anger was not adaptive. It probably wasn't adaptive with his wife, and it wasn't serving in such an adaptive way with the therapist. And then, but when he started getting in touch with the fear, it was much more adaptive. The therapist felt more connected to him and talked about that, and that was more useful. So these sorts of transitions between less adaptive and more adaptive task analytic approaches, qualitative approaches, are really useful with those sorts of things. So those were some things that were coming into my mind as I was listening and thinking about, of course, you could also interview the client and find out what the client was feeling. You could interview the therapist and find out what was the therapist thinking as she engaged in different interventions, and that could provide guidance for future therapists. So all of these research tools were in my mind. Yeah.
Maybe I'll pick up on that. But let me say something first. This is a clip that came from work I did with a colleague of mine, so I have more biases than usual in terms of talking about it. But I did want to say that up front. Let me begin with the research side of things, and something I wanted to say earlier that I did not, which is tracing the history of the rupture repair research. As Heidi highlighted, it really began as a task analytic application, which is inherently mixed method, includes quantitative and qualitative. For us, it was embedded within a randomized clinical trial, and we identified sessions with rupture and repair events, and we did a much more intensive analysis with a number of quantitative measures, but organized by, qualitative analysis. One of the products of that kind of work is more measurement development. For us, that means the 3RS, the measure that Jenny's working on, was really a product of all our task analytic work, with an eye towards doing more intensive and extensive analyses. Our original work applied a number of different measures of interpersonal behavior, emotional involvement, client vocal quality. It was a very intensive, labor-intensive effort, and it got a lot of attention. But if people look at the original work, it only involved a few cases, but it still got a lot of attention. We had always hoped to do things more extensively, but we needed an instrument to permit that. And the 3RS represented that. So it's part of that development. And it will permit, and it has permitted us to do more qualitative analyses, including patient therapist interviews of their experience. Because one thing I've learned over the years is observer recorded material doesn't provide you a complete picture. There's so much that's hidden. We were talking earlier about how great our presenters were and how well they masked their anxiety. But that's true when you look at videotape too. There's a lot going on that we can't see. And yes. This is where the qualitative method can really elaborate and provide us more about what's actually going on. So I'm as Heidi knows, I'm a big advocate for mixed method. Now,
but this also addresses Mark's question for transference and rupture.
Well, I was going to go right there. Yes.
Yeah, I knew.
You gave me a label. So let me, and this is going to build on also what Heidi said, but I want to address the transference question. I also want to begin with picking up on something that Mark said earlier about false dichotomies. And I don't think this is just a psychoanalytic endeavor, but I think as scholars, we should always be hunting and deconstructing false dichotomies. That should be really what drives our work. And transference is one of those concepts that begets a lot of different false dichotomies. So more specifically, our work, we found it more congenial to work within the intersubjective world. Because in this way, transference, unfortunately, can suggest, real versus fantasy. It could also tend to have this transference, countertransference thing where the therapist is just reacting to the patient. And so our thinking was always, we wanted to stay away from those traps. And we were developing our research in the intellectual milieu of the emergence of the relational movement in New York. So there were a lot of intersubjective formulations that were particularly helpful. Now, what does that actually mean? I mean, for intersubjective, what has been particularly influential is work by Jessica Benjamin and Lou Aaron, where they talk about the interface of patient and therapist respective identities and needs colliding together. And so one of the words I put up there is power plays. Okay, there's a lot of power plays that go on in any therapeutic relationship. And ruptures really reflect the collision of those power plays. And specifically here, what we saw was a confrontation. So totally right, frustration, anger. You saw the therapist kind of setting boundaries. She was actually being tough in her own way. Says, I don't do that in some sense. You're not going to get that here. Now, we can think about that in more sophisticated ways with regard to gender as well. But you're seeing this very interesting collision. And then, Heidi really identified the markers. And this is what's kind of useful about the task analytic method, because in the end, it probably yields the most clinically useful material where we're trying to sort of define markers. And we've talked about confrontation versus withdrawal, but then there's these mixed expressions that emerge in a repair or resolution process. And then there's this, in this particular case, it led to him becoming more vulnerable. Now, when we define confrontation ruptures, we invoke the patient struggling with their needs for agency and communion. We use that model. Maybe another false dichotomy, Mark, but but it can be useful. I mean, it's not that dichotomies are horrible, but we just have to remember what we're doing and how we may be really being Procrustean about things. But one way to understand a confrontation rupture is a person is pursuing the needed agency at the expense of communion. They're having trouble with that dialectic between agency and communion. And so in the beginning, he's confrontative, he's angry, he's frustrated, he's banging the door, give me, this is what I want. And that's him trying to be agentic, but obviously for the therapist doesn't feel a whole lot of communion in that moment. And then she sets her boundary and says, no, that's too much. That's, I can't do that. And then that triggers subsequent processes. And when he lands on being more vulnerable, then she can naturally connect with him more. So there's that experience of communion there, and she validates that. So there's a way in which he can and at the end, what's important is this expression of communion, but in an agentic way. So he kind of resolves the dialectic in that moment. And that's not an easy thing to do. And that's clearly something that he has trouble with. Now, circling back to the whole issue of intersubjectivity, we have our own histories with this. We have our own challenges with being agentic or, related. It's a dialectic. It's a tension that we as clinicians struggle with our own personal histories, own personal relationships with those needs. And of course, there are all these social constructions that color it. So, I can go on, but I'm going to stop there and open it up to anyone else. I'm sure Marie and Jenny have things that they can add to that or contradict.
Yeah, thank you, Chris. Regarding your last sentence, the social constructions, I found it quite interesting that he talked about the secret language that the therapist and his wife are sharing and he is not part of. And yeah, for example, this is something we found in the script at the end or when we are watching it. And I think also like ideas about therapy that you get an advice and then you're disappointed when there's none and so on. So there's many things you can go after and ask question about the perception of the client in this case, for example, as researcher but interested person, in the experience. Like just a comment to the secret language. We had this book in the 90s of our founder, Christa Daxa, of the expedition into the dark continent of women. Like that was a reminder for me that there is this idea. I don't know what is this secret language of women. Yeah.
I think that this clip also makes me think about just common factors and common processes across therapy orientations and how, we see the client moving through. I always find it so interesting when I see therapies done by different therapists who are really skilled, right? Like Catherine Eubanks, really skilled therapist who move the client through a process that another therapist from another orientation might move the client through a similar process through different prompts. And so I felt like as I was watching it, I was thinking this client has this maladaptive anger. There's some fear underneath it. How do I, so my response would have been to really talk about the anger more very directly and then really try to draw out the fear with the idea of, then having the client be able to think about, am I able to express fear to my wife? How would that be different? And Catherine's process wasn't my process, but she got the client to go to that fear. I'm scared of being alone. I'm scared of being abandoned. I'm scared. My mom left. My mom, we were uncertain would come back. My dad, we were uncertain would come back. There's a lot of the scary stuff. And so it's interesting to me how even using different kinds of prompts and therapy skills, I think that therapists who are very strong clinicians often move clients through similar kinds of processes. And to me, that's really interesting. I always find that super interesting to think about.
I just wanted to echo that. When we made these tapes, we got all these different actors, and then the whole conception of it was that Catherine and I would both see and work with each of these patients to demonstrate exactly what you're saying, Heidi, except, we were playing with the male-female difference, but it's different, different strokes for different folks. That old expression, or there are many roads to Rome, and Paris is a beautiful city too. So is Berlin. So, this idea that there can be differences in terms of how you work through things, of course, because therapists are different. I think we've always had this. It's true in psychoanalysis. You had to get your personal analysis so you can be like your personhood could be neutralized in some way. And in more recent examples, everything's getting manualized, so you can again neutralize the personhood of the therapist. And people are not paying attention to what the research is really saying. The personhood of the therapist is hugely important. And of course there are going to be different paths and different ways, and that's why we need to think more about principles than specific techniques. And I know this begets a whole other discussion, but I agree with you, Heidi, that differences are inherent and essential.
May I add something? Myself coming more from the Heidi hermeneutic qualitative tradition, but I still remember the possible discrepancy between rupture and transference, or the inclusion of rupture and transference. And maybe it's a little bit of a challenge, but I immediately understood that this was an actor. I felt it. And I think brain-wise, there must be a difference between an affect and an acted affect. It's just different brain charts, I guess. So maybe I would hand the question back to Mark, because I think when you pointed to transference, Mark, that you also wanted to say that the measurable rupture, that's what can be captured in the coding system, possibly is not what's going on inside. That was the challenge.
Well, since you invite me to speak, I will, but I won't only address the point you've made, but I'm also mindful of the fact that Jenny hasn't said anything, so I don't want to take up all the remaining time. I thought, of course, that the great risk, not only in science, but in life, is that you find what you expected to find, because you expected to find it, not because it's there. So here's a nice little illustration. And I thought, yep, you see in this clip, but by the way, I hadn't seen the clip before, because on my computer, for some reason, it just took 100 years to download. So I didn't watch it. So I didn't know what was going to come in the clip, but I think it showed illustrated exactly what I was saying earlier, that here we have clearly this rupture, which can only be called a rupture because that's what it was also a transference enactment. It was both, to Chris's point about false dichotomies. And then I think, and I won't explain why I'm saying that, because I'm sure we all know what I'm talking about. It was very clearly illustrated that this thing that happened between patient and analyst was also something that had deep meaning for him in relation to his own personal history, and so it was a repetition of something that's inside of him in the room between the two of them here and now. But I think what it also illustrated was the other point that I made, which is that I think countertransference in the old-fashioned sense of the word, in other words, what the analyst does, which is about the analyst. Which can be both constructive or destructive to the therapeutic alliance and to the therapeutic process. Here we saw that too. There would be many therapists who would not handle that situation as deftly as she did, and it could easily have led to an impasse and to a breakdown of the treatment. So that's the other point I was making, is that I think that it's not only transference, there's also the real for want of a better word, the concrete business of how do you deal with this rupture. It's not about the patient's transference. It's about the analyst's skill, and that includes not just their education, again, to the point that was made earlier, but also their personal attributes. And there I want to just add the remark that about the analytic neutrality that Chris was speaking about. I mean, it was a very unfortunate, I wouldn't say phase, it was because it was too long to be called a phase, but a very unfortunate feature of how psychoanalysis was practiced for decades. Because the caricature of the neutral analyst, and when I say caricature, I don't mean that it wasn't lived out. These caricatures, were actually enacted. It's not neutrality. It's weird. If you're with a person who's so blank and unresponsive and unable to actually address things directly, that's not an absence of something. It's a presence of something. It's like, what kind of person is this that I'm dealing with? So, thank God we are beyond that, and I think that the relational intersubjective sort of approach has helped us to get beyond that. Then one last thing I wanted to say by way of addressing this question of false dichotomies is that, and I'm really being very simple here. I know I'm being very simple, but it's no harm in addressing the simple things first. Is that the commonsensical question that arises at a moment like that is, does the analyst analyze what the patient is doing, or does the analyst address the issue realistically and say, no, this is not this kind of therapy, this is that kind of therapy, and that's why, we're doing blah, blah, blah. I must tell you, I think that, I know there's a taboo against the latter. One is supposed to analyze. One is not supposed to teach or explain or rationalize. And I don't see why you can't do both. I think it's perfectly possible to say to the patient, yep, that must seem odd to you that I'm not giving you advice. You're in such a desperate situation. Let me explain to you that why we don't do that is blah, blah, blah. And what we do instead is blah, blah, blah. And so, for example, you see what's happened here, it illustrates this thing, blah, blah, blah. And so you can do, if you're just an ordinary person and an analyst at the same time, which please God we can be, you can both address the commonsensical concerns of the patient in a commonsensical way, and you can analyze. And I think that that needs to be said. I'm mindful of the time. Sorry, I haven't addressed your question, Andreas. But Jenny, do you want to say something before we skip over to the last phase of our meeting?
So because I'm also focusing on adherence and competence, that just keeps coming to my mind, because seeing Catherine handle this situation so well and disclosing how she's feeling and the different kind of pulls she feels, and then also because I've done nonstop ratings this week, and seeing a lot of different therapists, how they handle tricky situations like these really severe ruptures. So how I keep asking myself, how much flexibility and responsiveness do you need? How much can you move away from the typical psychoanalytic interventions to be able to repair the rupture? What is authentic? Because I think Catherine was very authentic in how she handled it, and how we can kind of really research that, because it's very complex. I guess it kind of a lot of different aspects all of you were already talking about. So.
Well, I could be the devil's advocate here and possibly plea for not repairing ruptures instantly, just with a task of having the tension in the room and keeping it in the room, as long as I'm sure that we are not really shortly before a deadly rupture, So, but that would be a technical discussion. I think that could be thought about. But as I see that we are approaching the last quarter of the webinar, and this is dedicated to just switch from the case and from the research approaches to the experience of being a guest professor at IPU, and also because also Marie-Sophia and Jenny are invited, of course, to share their experience of being the counterparts and young researchers prominently working with our guests. So maybe we could really dedicate this quarter of an hour to reflect on the experience.
Do you want to suggest a sequence within which we speak, Andreas, or is it a free-for-all?
Free.
Well, since nobody else is jumping in and we have so few minutes, we mustn't waste them. I'll start just to say a few things. I won't be long. First of all, I think that it's a wonderful thing. I'm speaking about my experience of going to IPU. It's a wonderful thing to have an IPU. I'm not sure that people in Berlin or in Germany realize what a rarity it is to have such a thing as a psychoanalytic university. In fact, I think you can count the number of psychoanalytic universities on one finger. I think you are the only one. A psychoanalytic university, as opposed to a division or unit or department. There's the only comparable thing I'm aware of is the Sigmund Freud Institute in Frankfurt, which is also in Germany, which might make you all the more not realize what a precious thing it is that you have. To have two academic institutions devoted to psychoanalytic research and education is just fantastic. And therefore, to be there as a guest professor or visiting professor, I forget which one we are, it's a great experience. To be immersed in that environment is fantastic. And it's what struck me. I mean, maybe you're getting, all of you, the impression that I'm a kind of very positive, gung-ho sort of guy. I'm quite ready to be nasty and critical when it's necessary. So the fact that I'm being so positive is because it was such a positive experience. What I experienced was young people with good minds being excited about and interested in psychoanalysis. And I don't know about Heidi and Chris, what your experiences are where you are based, but, it's not like that here, I tell you. I mean, there are people interested in psychoanalysis, but not in the university. And also the people who are working in the field are mostly my age, to see young people being so excited and enthusiastic and interested in and developing advancing, psychoanalytic science and culture and practice. It's just, it was a wonderful thing. So I very much hope you're able to keep this program going, because I imagine it's also a good thing for the students and the faculty to have visitors coming from outside. The feedback I got from the students was that, the particular link that I provided between neuroscience and psychoanalysis, they get neuroscience and they get psychoanalysis, but they don't get the link. So, you parachute somebody in, they provide something that's not normally there. That's very good for the institution. And I'm sure the same applies in the case of Heidi and Chris. In other words, that they provided something. You can see it from the presentations, for example, today. They contributed something that. There's a hell of a lot more I could say, but those are the most important things. If it turns out that there's silences, I'll have plenty to add, but those are the main things I wanted to say. It was a great experience. We'll just squeeze one further thing in. I was the first one, and IPU wasn't used to how to deal with people like this. And I was very pleased to see that when I came back again, but by which time I was sort of the fourth one because I went twice, it was a well-oiled machine. And so you've clearly learned how to do this thing now. Thanks so much.
I could go next because I was the second person to come in. And I was just so happy and honored to receive the invitation. I had written before with Michael Buchholz and Alexander Dmitrijevic and on silences and psychoanalysis. And so I was very excited to have the chance to be talking with colleagues. And so much thanks to Andreas for his gracious welcome and willingness to share office space and just making everything move smoothly. I found it so pleasurable to have a chance to talk with colleagues, to consult with people. I really enjoyed talking with Marie and with Christian Steinhardt and learning about different projects that were going on, and getting to talk about them was just such a joy. Some outputs we have, I'm the editor for Qualitative Psychology, and so Gavin Sullivan has proposed a special issue based on our conversations while I was there, focusing on visual methods of data collection and qualitative methods. So I'm super excited about that as an outcome of my stay. Also, as Andreas mentioned earlier, we had this international project that we developed, where we had qualitative researchers from 10 different countries around the globe coming to talk about the importance of including qualitative research when countries are developing recommendations and guidelines for psychotherapy practice, right? So to better include all of the rich qualitative and process kinds of research that have been happening within psychoanalysis and other therapies that are not having their work be represented typically. And so this is, I think, a really important thing. And I'm excited to see, shifts happening and this project moving forward. And also just really having enjoyed spending time with the students. I also experienced just time with all of you is so pleasurable, and enjoyed your excitement and interest in both qualitative methods, qualitative methods, psychotherapy research, and also LGBTQ kinds of research, right? There was a lot of excitement about talking about topics around feminist and gender theory, and thinking about how does that connect with psychoanalytic theory. So it was just overall really wonderful. Thank you.
So let me echo what Mark and Heidi said. I couldn't agree with them more. In terms of the reception, I was so impressed and grateful for the hospitality and curiosity from the faculty and students, to Garo especially, and of course Jenny, who sort of guided me along, make sure I didn't get lost in Berlin. We also, my wife and I, really fell in love with Berlin, and so much so that I kind of did a weird thing last night. I mentioned earlier, I Googled the apartment we were staying in, and I noticed it's still available, or at least it's posted and it's still available. But it really felt like our apartment, and it feels really weird that someone else could be living in it. What else will I say? Well, I think for those of you who know me, I've always had this lifelong interest in negotiating difference, and there are many ways to account for that. As an adolescent, my intellectual champion was Albert Camus, and so I was really immersed in his struggle with negotiating difference, and so that's always been at the heart of my thinking. I've always had a penchant as a result for pluralism. Why is this relevant? Because when it came to IPU kind of stirred up old questions for me about these things, and so including, like, what is psychoanalysis? What has it been? What can it be? How do we position it with regard to other psychotherapies? How do we understand the subjectivity or the identities of the analyst with regard to the patient? I've spent a lot of my career kind of above the fray, thinking about psychotherapy in a very general sense and not, even though I had this analytic training, I really kind of, stayed more ensconced in the psychotherapy research world. Yes, rupture repair certainly has its roots in psychoanalysis, but it has roots and connections to other things as well. And I think coming to IPU has really not made me an analyst. I have analytic training, but I don't usually use that identity. But it has made me more sensitive to its place in our intellectual world. And it has made me more sensitive to, especially, and Heidi can appreciate this in the US, it's atrophying presence. So I think IPU has really made me a little more vocal, a little more protective. I will be inherently a contrarian forever, I'm sure. And sometimes when I'm in a community of analysts, I'll be very challenging, and I'll do the opposite in the cognitive behavioral world. I'll be very, that's just what I do, but it's all about trying to understand differences. And I'm very grateful for IPU, and Durner or Delphi is very grateful that I'm actually more sensitive to psychoanalysis, as well as my affiliation with NYU. So I appreciate that. I appreciate the experience, and I hope it was rich for all of you. And I agree that it would be a great thing to see you continue this. So thank you.
So these were wonderful words from all the three of you, but would possibly our younger researchers add something if they like?
Maybe we keep the order. So maybe I can start from our research perspective. I think the reflection I can make on this time, especially working together with Mark during these 2 semesters, is a very personal one, because I've been studying my bachelor's and my master's program at the IPU, so I was used to having a certain kind of psychoanalytic perspective onto things. But I've always been working in certain labs for collecting EEG data, evaluating EEG data on the side. So the combination of neuroscience and psychoanalysis and looking at psychoanalysis through the eyes of cognitive neuroscience is something that has always been missing for me as a student during my time. And unfortunately, I was already too old to experience Mark's lectures as a student, although I had the chance to attend one of them. I was lucky enough to be part of this wonderful project. And I remember when we started this journey together with Mark, Tamara Fischman, Christina Stelzel 2 years ago already, it's been quite difficult. And I remember asking or hoping to make a contribution to the field of neuroscience and neuropsychoanalysis, and Mark's answer to that wish of mine was, let's separate panic and grief. And so it's been a wonderful time, and I will always remember the time that we spent together, Mark and I, through these many, many hours of meetings and discussions that we had. And I'm very thankful for the trust and to be part of this project.
Yeah, my comment is also a personal one. I already mentioned your value, Heidi, for our whole team at the beginning of our project. But especially for me, it was at that moment a time when I started my personal project coming from a quantitative area in psychotherapy research back to a qualitative area. And I was actually trained as a cultural anthropologist. So it was kind of in coming home to my earlier roots, and it was so exciting to see this thick descriptions right now in the reports of the patient. And also, and this is another thing, what you taught the whole seminar, and also when we talked in our team, that you also underlined the importance of reflexivity and introspection, the whole process, research process all over. And I think this is also quite a psychoanalytic behavior or attitude, just to reflect your position, your power. And yeah, that was really important and is still important. And thank you very much.
Yeah, I'll just quickly add to that. So really participating in, because I took 3 of Chris's classes. So that was really amazing because it really opened up new perspectives onto research, but onto psychoanalysis as well. Because yeah, I guess it's a special kind of psychoanalysis, or like special view we get at IPU in some classes. And it was really eye-opening for me to see what kind of was missing for me before, and I didn't even notice until I had those classes with Chris, and it was very interactive. And it really, because I just started my training as well, that was really influential to me to what I want to become, like what type of therapist as well, and kind of seeing how fruitful our discussions, especially in the research forum where I presented a project, and now this project I presented today kind of emerged from that discussion, and how amazing collaboration is. Like, I'm eternally grateful. So it was a really, really good experience. Thank you very much. And I think that it was for the students as well, and also for the faculty to, like, because it changes the dynamic when you're at our university and participating not just in classes, but also like,
Yeah, wonderful. Thank you very much. I'm much, of course, representing IPU. I much appreciated Mark's remark about the unicality of our university. But I would add something to it, because we are a psychoanalytic university, but we are not ruminating psychoanalytic theory. We are a very interdisciplinary thing in itself. And so when you also kindly remarked that our presenters were not cherry-picked, but like representative of the young research culture at IPU, I would say yes, but the guest professors, they were cherry-picked. So I really cherry-picked you, and I'm very grateful to Dorothea Huber and Michael Buchholz to help me, like, fish some of you whom I did not know in person before, but I'm very, very happy to know you since. And I had a very interesting discussions with all the 3 of you. So I do think that the founding impulse of our university, which, was an idea of Christa Rode-Daxer and Jürgen Körner, it was really to bring psychoanalytic debate in contact with the academic research, because we feared that psychoanalysis could become something extra academic, something like private, and something like a religion. And that would be really a pity, because Freud was, and I enjoyed, Chris, what you said a lot about being in between, being a challenge to analysts and a challenge to CBTs. Yeah, but I think basically psychoanalysis has a position in between. That was from the beginning. Freud was a neuroscientist and an archaeologist at the same time. And these are not like compatible disciplines in the first place. So I thank you very much for giving us at IPU this wonderful experience of having you. And I think Horst, if he would be with us, he would really love, and he would be very loud, because he didn't used to talk silently. He would be really applauding and very happy that we did this, and we did this in his name. So thanks to you all. And thanks to our nice audience. We kept you a little in silence, but you understand, 6 people's on the panel. We just wanted to give space to all of them. Bye-bye, and have a good weekend.
Thank you. Thank you so much.
Bye-bye. Thank you.
Bye-bye.